Good morning. We're here today to talk about Millennium's Cardiovascular Disease Project, Project 3BI, and implementation of this project in the region. So, primary care implementation of the Cardiovascular Disease Project. We had done a webinar of this on February 28th, and this recording is really what we talked about at the webinar. To give you a brief overview, Millennium's Cardiovascular Disease Project has a number of deliverables that are due to the state on 3/31/2017, that's March 31st, 2017. And these include creation of registries with our primary care partners for patients with high blood pressure who do not have a diagnosis of hypertension in their record, or for patients with a diagnosis of hypertension who have not been seen recently by their physician. Training. And this really, if you're listening to this webinar, this would be the training to learn more about Millennium's Cardiovascular Disease Project. You can access this through HW Apps, which is our online learning management platform that has a number of different courses for different projects. Policies include self-monitoring of blood pressure and walk-in blood pressure checks for patients who do not have a scheduled appointment. The tobacco cessation policy will walk through asking patients if they are smokers and what to do if a patient is a smoker, including the 5 A's of tobacco control. We will also introduce some best practices and workflows focused on managing hypertension, high cholesterol, and tobacco cessation. And finally, quarterly reports, which I am very sure that many of our practice partners are submitting every quarter to our Millennium team. These are really unique patients who have self-management goals noted in their medical record, and the quarterly reports are sent via Watchdocs, which is our secure management tool. If you have not sent a quarterly report in yet, I'm sure you can connect with your practice transformation team, and they will introduce you to Watchdocs and also give you the template for the quarterly report submission. So, before we talk about Millennium's project, we're just going to talk briefly about an overview of what's happening with cardiovascular disease nationally. So 1 in every 3 deaths is caused by heart disease and stroke. They account to a staggering $312 billion in healthcare costs every year. Cardiovascular disease and strokes are the leading cause of preventable death, particularly in young people between the ages of 40 to 65 years of age during their prime working years. There are annually 2 million heart attacks and strokes. This amounts to 1 heart attack or stroke every 40 seconds. Now, in the region, in the Western New York region, high blood pressure, cardiovascular disease, and coronary heart disease, as you can see in the table here, for Western New York, have a higher prevalence than the New York State average. Cardiovascular disease is the leading cause of death and hospitalization across our 8 counties. High blood pressure, patients with high blood pressure often end up in the ER and often end up hospitalized, and so our focus really will be to manage patients in a primary care setting so that we are avoiding preventable hospitalizations and ED visit for hypertension, which is an ambulatory sensitive condition. Some of the factors that actually lead to cardiovascular disease, there are non-modifiable and modifiable risk factors. The non-modifiable risk factors include your age, gender, and family history. However, a significant portion of cardiovascular disease is connected to modifiable risk factor. The ones we'll be focusing on today are high blood pressure, high cholesterol, and smoking cessation. Millennium's Cardiovascular Disease Project is focused on implementing evidence-based strategies to prevent and manage cardiovascular disease. It is aligned with the National Million Hearts campaign, which focuses on 4 basic things, the ABCS. That is aspirin therapy when appropriate, blood pressure control, cholesterol management, and smoking cessation. All of the strategies and guidelines we will present today are based on this National Million Hearts campaign. To begin with some of the district deliverables, I will start with the registries. So we are working with our primary care partners, with you, on developing registries that we can use to monitor patients who have diagnosed hypertension, defined as hypertension greater than 140/90, or patients with a high blood pressure value but with no formal diagnosis in their medical record. This includes patients with stage 1 hypertension at 2 or more visits, or stage 2 hypertension at 1 visit or more. So what we're asking from you is really a screenshot of the output. If you run a report of your hypertension registry, then we're looking for a list of patient names, IDs, appointment date, and the services received at that appointment. And the New York State DSRIP project requires that we submit this data to New York State by March 31st, 2017. Millennium also has many trainings on our HW Apps Learning Management tool. To get to our trainings, you start at the millenniumcc.org website. If you scroll to the bottom of the website, you see the orange box that says Training and Education, and if you click on that link, it will take you to the HW Apps platform. If you have never had a training on HW Apps, it will prompt you to register. Set up a registration with your ID and password, upon which time you will be able to access many of our courses that are listed. The Cardiovascular Disease and Million Hearts course is next to this purple logo here. And to access this course, you can choose by partner type. So if you look at the blue arrows, you can see we have selected primary care as a partner type. And if you choose required, then if you search by primary care and required, you will definitely pull up the Cardiovascular Disease or Million Hearts course, which is right there. I will now hand it over to Laura, who will talk about some of the policies that we have been working on. You could use our templates, or you could modify as you see fit for your practice. Sorry about these technical difficulties. There we go.
Can you scroll it up just a little bit so they can see the body of it? So basically, for the policies, what we're looking for is for you to provide us with your blood pressure monitoring policy. And if you don't already have one, we're providing you with this sort of a template. You may use this in Word format and alter it a little bit to be specific to your workflow. Basically, what we're looking for are 2 different concepts. First, the walk-in blood pressure check procedures, where you will describe to us what your process is for accepting patients to walk in with no scheduled appointment, just for a blood pressure check, and no copay is required at this time for these patients. If you need help working through the concepts of this, you're welcome to talk to your practice transformation specialist to help you figure out ways that you can work this out in your office. The other concept we're looking for is self-monitoring of blood pressure. So as you can see here, there's possibly several different ways that people can do an at-home blood pressure monitoring, and that includes, if possible, through their insurance, a device that they can take home with them. It would be appropriate for them to receive a log where they can register their blood pressure readings and then return them to you at the following visit to discuss their ongoing hypertension treatment. So again, if you haven't already received these templates, you can ask your practice transformation specialist for them. They're also housed on our website right now under the ambulatory services section in an area called resources. So you can help yourself with those and make them your own, and then once they're finalized, specific to your office, return them to your practice transformation specialist as substantiating documentation that these are the policies that you're using in your office. So we've also included in this a best practices blood pressure check workflow for you, and this has been approved by our subcommittee. Basically, it talks about a patient coming in, waiting 3 to 5 minutes to just calm down from the drive or whatever was happening to them before they sat down and took a couple of breaths. Check the blood pressure at that point. If it's within a normal range, clearly nothing more is needed. But if it's equal to or greater than 140/90, that patient will wait a couple more minutes, 10 minutes, and the nurse will do a recheck at that time. After the recheck, if everything's fine at that time, clearly nothing more needs to be done. But if it's reading high again the second time, 10 minutes later, we recommend that you schedule an RN recheck in 2 weeks and also schedule a PCP visit for a month out. Clearly, if it's dangerously high, you would refer them to the emergency room. Also included is a nice instructional sheet that you may use to pass out to your patients who are doing at-home readings, and this just gives them a little bit of guidance as to how they're going to be taking their pressures.
Great, thank you, Laura. We will now switch to another policy, which is our tobacco cessation policy.
Okay, so here you'll see our sample referral for smoking cessation. And again, if you have your own policy that you're using in the office for this process, please share it with your practice transformation specialist. And if not, you're welcome to use this. If you don't already have it, again, it can be found on the website. Alter it if you need to represent the workflow in your particular office. Put your own heading on it, and then it becomes your policy. And this basically just outlines a quick and easy workflow for referring your smokers to the quit line. And please also notice that there's a quit line referral specifically designed for pregnancy. So you may also refer your pregnant tobacco users, and they will have their own set of guidelines.
Thank you, Laura. And now we'll hand it over to Dr. Davis, who will discuss some of the clinical algorithms and best practices that we've been working on. This includes the Million Hearts algorithm, which covers all three: high blood pressure, cholesterol, and tobacco cessation. The blood pressure management best practices, which includes blood pressure management for patients with uncomplicated hypertension and comorbid conditions. And finally, cholesterol management, including initiation of statin therapy, ongoing monitoring, and a workflow for cholesterol management. So I will now pull up the algorithm, starting with the Million Hearts algorithm. So what you will see here is the Millennium's it's on Millennium template, but it's actually the ASCVD risk algorithm.
Thank you, Priti. First, I want to say thank you, everybody, for joining us on this webinar. I know everybody's busy, so thanks for making cardiovascular disease a priority within your practice. So what I'd like to do is kind of take the time out to put everything together and say, how does all of this work in my clinic? How am I going to move the needles on my patient? So I want to walk through the first part, which is the Million Hearts algorithm, which you're looking at now. This is basically a summary, and then we'll take it into a more granular level. The very first section that you're looking at talks about tobacco cessation, and that's when we start launching into the 5 A's of tobacco cessation, which there is a policy for that as well. Just in case, the 5 A's are ask, advise, assess, and assist, and arrange. So the very first thing you're going to do is the very first thing that you're going to do is at least look to ask. It's a simple question: are you a smoker? Are you not a smoker? Then the next part of it is blood pressure control. I want to refocus again on the goals, for the Millennium goals, it's 140 over 90 for 2 visits, or 160 over 100 for 1 visit, and that was done in a previous slide. These aren't the new JNC 8 guidelines, but these are the ones that are endorsed by the Million Hearts initiative, and those are the ones that we are using for our population health. So that second segment is talking about blood pressure control. The very last segment is talking about cholesterol guidelines. I'm not going to go through the entire cholesterol guidelines for the simple fact that I want you to realize, for the practitioners out there that are listening, this is not new information. These are all things that we know. We're just putting it all together in a streamlined flow so that you can see kind of how it all works together. These lipid guidelines are the same ones that were published by the AHA circulation. All right, so moving forward, so let's break it down. Let's break it down and talk about actual blood pressure management. So before I start on that, I just want to kind of throw out a little bit of stats. Some of these are a little older, but they're the most newest ones. So N. Haynes in 2011 and 2012 looked at the prevalence of hypertension on a national level. 83% of patients who had hypertension were even aware that they even had it. 76% of those were taking medications. And out of those 76% that were taking medications, only 52% of them were controlled. So when you look at that on a national average, only 52% of those people who are aware that they even have hypertension are even controlled. What we do know, and which was also further extrapolated from the CDC, was that just a 12 to 13 point reduction in systolic blood pressure drastically decreased cerebral vascular accidents by 37%, coronary heart disease by 21%, and death from CVD by 25%. This is how important just managing blood pressure is, which is such a modifiable risk factor, especially at the primary care level. It doesn't take much. It just takes recognizing it, measuring it accurately, and acting on it swiftly. So with that said, I want to present 2 different algorithms that you can use within your clinic. And once again, depending on how your clinic is structured and the type of participants you have in your clinic, whether you have a physician-heavy practice or you have a mid-level heavy practice, will dictate which algorithms you want to use. The very first one that I want to point to is option 1. This is for somebody who has more comorbidities. So you might want some of your higher level practitioners using an algorithm such as this. This algorithm will allow you to take care of people with coronary artery disease, kidney disease, heart failure with reduced EF. This is the option that you would want to use. I also want to make reference to the intervals. If you notice that one of the systolic blood pressure over 160 group, that you're actually rechecking and reviewing readings within 2 to 4 weeks. In my practice, I tend to be very aggressive with blood pressure management, so I escalate medications fairly quickly. And my personal belief is that I have the medications, I can drop the blood pressure relatively quickly and safely, so I might as well do it. And that's just because cardiovascular disease is such a killer amongst our population. So this is option 1. The next one I want to show you is option 2, which is one that I actually recently found out about and recently used, and I'm becoming a big fan of it. Option 2 is for uncomplicated hypertension, and it's with the STITCH algorithm, which stands for Simplified Treatment Intervention to Controlled Hypertension for Uncomplicated Patients. So once again, this is somebody who comes in who's maybe 45 or 52 or 53, and they have no other comorbidities except for an elevated blood pressure reading. This one is very simple and can be done easily with minimal effort and minimal staffing. And it's basically, if I point you to option number 2, which is the one that I like to use in my African American patients, which is amlodipine. You give them 5 milligram tablets. You tell them to recheck their blood pressure if it's still elevated within 2 weeks, and they take 2 tablets. And if you follow the blood pressure algorithm that we said prior, they're going to come back and see you in a month. So these patients may still be controlled on 5 milligrams, or they may be controlled on 10 milligrams. By the time they see you, they'll already be escalated. This is nothing different than what we do when we manage insulin in diabetics and we have them up-titrate their own medications. Nothing different. So this is one that you can use for uncomplicated hypertension patients. The next thing that I want to attention to is the cholesterol guidelines. And once again, I'm not going to harp too much on the nitty-gritties of it, but I just want to show you the actual algorithms that we have. So on the front page of it, you actually have initiation of statin therapy. And this is using your ASCVD risk calculators. And I know there's a lot of controversy on which calculator to use. Are you using the ASCVD risk calculation, or are you using the pooled risk calculator with Framingham? Which we're not stating which one you should use. Whichever one that your clinic is comfortable with, whichever one you're comfortable with. Here are how we use the guidelines. Once again, these are the same ones that were published. On the back of this sheet, we actually have statin therapy monitoring. So how do you monitor somebody who's on statin therapy? And then right below that, we actually have the intensities of the statin, as well as the U.S. Preventative Service Task Force guidelines for primary use of statin therapy. Once again, this is just putting everything that was already published on one sheet for you. So now I want to move into, now that we went over all of the different things, the 5 A's of smoking cessation, option 1 and option 2 of hypertension management, as well as cholesterol guidelines, what does that look like? So let's run through a scenario, okay? So how do we get everybody involved in this? The theory behind population health and really working these registries and moving the mark and transforming your practice is you want people working at the optimum level of whatever it is their degree is. So maybe it's not advantageous to have a physician see somebody who is 42 years old with just hypertension. You really want that physician to be seeing somebody who's got CAD, CHF, asthma, uncontrolled hypertension, and diabetes. That's really where you want them to concentrate their efforts at. So maybe some of this stuff can be managed by the rest of your practice and some of the mid-level providers through algorithms. So maybe the very first thing you want to do is your chart prep team. Your chart prep team the day before is usually going to prep your charts. So maybe you want them to look through and see if they have a fasting lipid panel somewhere, and maybe you want them to calculate the ASCVD score. So for us, we utilize Allscripts. So for us, in my practice, what I do is I calculate the ASCVD risk score, and we actually have a banner that we put it on. So maybe you would have to look in your EMR to see where you can place that ASCVD score. So then, once that's done, it's flagged for the PCP. So now taking you to the next day, the patient actually comes in. So now your intake team, so whether it's your MA or your LPN, whoever rooms the patient for you, they notice that the ASCVD score is calculated. And so now part of their practice is they're asking the patients, are they on a statin? Are they having any issues with the statin? And now they're actually going to utilize that page, which is the statin therapy, the monitoring therapeutic response flow. Then from there, let's say they're intolerant to a statin. So maybe you want that MA or that LPN to put in the chart that the patient is intolerant to statin. And so then that's flagged. And so then now when your practitioners walk into the room, everything's already done. The ASCVD score is already done. The last fasting lipid panel was already pulled up. You already know if the patient's on a statin, if it needs to be adjusted, or a CMP or LFTs need to be drawn now. All of the work that sounds very easy, but when you're seeing 20 patients a day or however many patients you see, and everybody has many different complaints and issues that you're trying to address, some of these things are very important, but they fall through the wayside, and that's for the best practitioner. And so it's already done, it's in your face, and now you can address the need. So this is one way that all of this can be utilized within a practice to help move the mark within your practice. Thank you.
Great, thank you so much, Dr. Davis. We will now move on to our quarterly reporting. So our practice transformation team has been working with many of our practices on receiving quarterly reports through our secure file management process, file transfer process, watchdogs. And these include Excel report submissions every quarter of patients who have documented self-management goals in their medical record. These goals can include diet, exercise, monitoring of blood pressure, whether they are lowering their sodium intake. These must be patient-driven and noted in the medical record, and a quarterly report is then pulled and submitted to our transformation specialists who or submitted through Watchdocs, our secure file transfer system. We ask that you submit your quarterly reports in these months by the 15th of every reporting month, which includes January, April, July, and October. And again, this is what Watchdocs looks like. If you have not had a chance to use Watchdocs, please contact your Millennium Practice Transformation team, and they would be happy to help you get set up so we can secure the quarterly reports every quarter, which have to be submitted to the state. Just to bring this whole presentation into context, Millennium has worked with you to really set up some processes in place to manage both high blood pressure and high cholesterol. However, we are being held to some very stringent performance metrics over the next 3 district years. These performance metrics, some of them are HEDIS metrics you may be familiar with your work with the health plans. This includes controlling high blood pressure, statin therapy for patients with cardiovascular disease, as well as monitoring of patients who have cardiovascular disease and schizophrenia by getting them a test for LDL cholesterol on a regular basis. And it also includes 2 AHRQ indicators, which are preventable admissions for hypertension and preventable admissions for heart failure. All these performance metrics are associated with dollars for DISRIP, and they come with annual targets. If Millennium does not hit their annual targets, then it decreases the funding that we get from the state and therefore the funding that we flow to our partners. So while we are working on setting up processes and policies and workflows with you, we're also looking forward in the future to implementing these to ultimately impact our performance metrics that are listed here. And I just wanted to point out that we also have a CME coming up for talking about patients who have both cardiovascular disease and behavioral health issues. The panel of speakers is listed here, and it will be on March 22nd from 6 to 8 p.m. at Giancarlo's. We have listed here who should attend and some of the topics that will be addressed during the CME. If you're interested, please contact the Practice Transformation team, and we will be more than happy to sign you up for this CME event. And finally, I would like to thank you so much for your time today. We appreciate your attention, and we hope you found this recording useful. Thank you. From the entire team, Laura Kennedy, Dr. Kiki Davis, and myself, Priti.